typically will require sequential additions of antihyperglycemic agents, and in many patients culminating in the addition of insulin. On the other hand, patients and providers typically have a reluctance to initiate insulin due to concerns regarding hypoglycemia, weight gain, or simply the complexity of insulin therapy. Sitagliptin, which is an oral DPP-4 inhibitor, is approved for use as monotherapy and in combination with oral agents and/or insulin. But there are limited data regarding the impact of sitagliptin on delaying the progression to the need for insulin initiation. TECOS, which was the sitagliptin cardiovascular safety study, provides us with an opportunity to assess the patterns of insulin initiation in patients with type 2 diabetes not using insulin over a median follow-up in the study of approximately 3 years. TECOS was a multinational cardiovascular safety study evaluating the impact of sitagliptin versus placebo when used in addition to usual care on a composite outcome of 4-point MACE: cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for unstable angina. The TECOS study enrolled 14,671 patients in the ITT population. All participants had a prior history of cardiovascular disease, type 2 diabetes, with a hemoglobin A1C at entry between 6.5 and 8.0%. They needed to be treated with either mono or dual combination therapy with metformin, pioglitazone, or any sulfonylurea, or they could have been on insulin with or without metformin. Diabetes management throughout the course of the study was provided by the participants' usual care providers based on local treatment guidelines. The primary endpoint, which was reported 2 years ago, showed that that sitagliptin, added to usual care, did not increase the risk of major adverse cardiovascular events, nor of hospitalization for heart failure or other adverse events. The time to initiation of chronic insulin therapy was a pre-specified endpoint in the study. This was defined as a continuous period of insulin use of more than 3 months amongst participants who were not receiving insulin at baseline. So from the ITT population of 14,671 participants, there were 11,263 who were not using insulin at entry into the study. Treatment with sitagliptin was associated with a reduction in the rate of initiation of long-term insulin therapy compared to placebo. The hazard ratio was 0.7, with a p-value that was less than 0.001. For these analyses I'll be discussing today, we look to evaluate the likelihood of progressing to insulin therapy in those participants who were taking the most commonly used antihyperglycemics at baseline of the study. This included metformin monotherapy, sulfonylurea monotherapy, and the dual combination of metformin and sulfonylurea. During the course of the study, at study visits, concomitant antihyperglycemic medications were recorded. Amongst the participants not using insulin at baseline, we summarized the proportion that were starting long-term insulin therapy as previously defined, and a time to insulin initiation was estimated using a Cox proportional hazards model stratified by region. The model results will be presented as unadjusted hazard ratios and p-values. Here you can see the baseline medication use for the population. 23%, as mentioned, were using insulin at baseline. They're not the subject of this analysis, of course. So amongst the 77% that remained, monotherapy was used in 51% of the non-insulin users, and dual combination therapy was used in 49% of the non-insulin users. Within the category of monotherapy, metformin was used by 77% and sulfonylurea monotherapy by 22%. Within the category of dual therapy, as you can see, the vast majority were on metformin and sulfonylurea. And those are the groups that comprise the focus of this analysis. On this slide, we break out the baseline characteristics for the monotherapy group and for the dual therapy group. Monotherapy users, compared to the dual therapy users, had a shorter duration of diabetes, a median of 6 years compared to 11 years for the dual therapy users. And they also had a slightly lower hemoglobin A1C level, 7.0 as compared to 7.3. In drilling down to the monotherapy populations, you see here in the table on the left the metformin monotherapy group and on the right the sulfonylurea monotherapy group. Metformin monotherapy users tended to be younger. They had a shorter duration of diabetes. Here we see the median of 4 years compared to, median of 6 years compared to a median of 8. And they had higher eGFR levels, 77.4 versus 70.7. In those subjects who were not taking insulin at baseline, insulin was initiated in 4.7% of metformin monotherapy users, 11% of sulfonylurea monotherapy users, and 17.2% of the dual therapy metformin sulfonylurea cohort. In the table at the bottom of the slide, you can see the breakdown by treatment group. For the metformin monotherapy subgroup, insulin was initiated in 5.5% of the placebo group and 3.8% of the sitagliptin group. For the sulfonylurea monotherapy, it was 11% and 10.7%. And for the dual combination, 20.4% of the placebo group and 14.0% in the sitagliptin group required the initiation of chronic insulin therapy. The next several slides will show the data regarding the time to first event analyses. The event rate in the metformin monotherapy subgroup for initiating insulin was 2.0 events per 100 patient years in the placebo group compared to 1.3 in the sitagliptin group, hazard ratio of 0.67, which was statistically significant. And you can see the pattern over time in the insert in the lower part of the slide. Here we show the data in the sulfonylurea monotherapy subgroup. 4.2% of the placebo group versus 4.0% in the sitagliptin group. While the curves appear to diverge over time, this difference with a hazard ratio of 0.96 was not statistically significant. Finally, in looking at the dual therapy group, 7.8% in the placebo group versus 5.1% in the sitagliptin group progressed to insulin, providing a hazard ratio of 0.64, again, highly significant. And here we can see the differences emerging in the curves in the bottom of the slide, generally within the first year, but there appears to be some divergence over time. There are a number of limitations to these analyses, which I must point out. First, TECOS enrolled mono and dual therapy participants who may not be representative of the wider population requiring progression to insulin. Importantly, these were individuals who were relatively well controlled at entry with a hemoglobin A1C below 8%, as well as having well-controlled cardiovascular risk factors. Also, these observations were limited to the effects observed over the overall median follow-up of approximately 3.1 years. During follow-up, drop-in therapy with other anti-hyperglycemic agents was permitted and may have been imbalanced between the two treatment groups. And the addition of open-label DPP-4 inhibitors and GLP-1 receptor analogs was not permitted, thus limiting some alternative options to insulin for intensification of diabetes therapy during the course of the study. So in conclusion, among a cohort of international clinical trial participants with type 2 diabetes and cardiovascular disease who were well controlled with mono or dual oral agent therapy, the rates of progression to insulin use were higher in sulfonylurea than metformin users, and highest in those taking metformin and sulfonylurea dual therapy. Secondly, randomization to sitagliptin compared to placebo was associated with a delay in progression to insulin initiation amongst patients taking metformin or sulfonylurea monotherapy and in those patients taking metformin sulfonylurea dual therapy.